السلام عليكم. هنبدأ محاضرة النهاردة في جزئين من المحاضرة. الجزء الأولاني بنتكلم على الفيميل جينيتاليا الأوفري واليوترس، والجزء الثاني من المحاضرة هيكون على المامري جلاند والافكشنز بتاعتها. عملية الأوفري هيستريكتومي هو إن احنا بنشيل الأوفري وبنشيل اليوترس. احنا كنا في الطبيعي دايما بنقول العمليات نبدا بامتى بالعمليه، نقول از تريتمنت لحاجه معينه، لكن الاوفري هيستريكتومي از نوت تريتمنت، بقدر ما ان هي بعض الاحيان او في اغلب الاحيان بتكون الكتيف سيرجري، علشان صاحب الحاله بيبقى خلاص لا مش عايزه تيجي في الاسترس، لانه لما بتيجي في الاسترس بيبقى الهرمونز وكده بتخليها بتبقى مور اكتيف، بتبقى نيرفز كتير، ممكن تنط، ممكن بتاذي نفسها. بلس ان هو مش عايز بيبيز، خلاص مش عايز اوف سبرينج، فبنضطر ان احنا نعمل عمليه الاوفري هيستريكتومي، وفي الحاله دي بتشيل الاوفري وبتشيل اليوترس مع بعض. طيب برضو في كام نقطه كده نبقى عارفينها. هو ايه اكتر ايج يبقى سيف ان احنا نقدر نقول انه يس وي كان ستارت ان احنا نعمل العمليه دي؟ قالك بدايه من 7 أسابيع، لكن برضو تخلي بالك انه في هاي ريسك من اليورينري انكونتيننس لو تمت العمليه دي قبل 3 شهور من العمر. برضو بنبقى حاطين في دماغنا انه بما انه احنا كده عملنا disturbance في الهرمونز، هرمون الاستروجين لو شلنا الاوفري فهيبقى في الجروس بليت مش هيقفل بسرعه، هياخد وقت اطول شويه من 8 ل 9 اسابيع، وبالتالي الحيوانات اللي بتعمل لها الاوفري هيستريكتومي في عمر بدري شويه بيبقى العظمه بتاعتها تبقى طويله، بيبقى اطول من العادي. برضو من ضمن الحاجات اللي احنا ناخد بالنا منها انه الفالفا هتبقى طبعا صغيرة في العمر، برضو علشان الاستروجين ملهاش اي علاقة بان الحيوان يبقى فاتي او الاباسيتي تبقى عالية، ملوش اي علاقة برضو بان هو ملوش انه يعني ما يبقاش ليه نفس ان هو ياكل، او ان نفسه مثلا تتفتح للاكل او الكلام ده كله. العملية ملهاش اي علاقة. العملية بقى بنعملها ازاي؟ المفروض ان احنا لازم نبقى عارفين احنا بنفتح فيه. ان افضل مكان للفتح هو الكرينيال سيرد اوف ذا كودال ابدومن، من بعد الامبليكس يبدا ده المكان ده افضل مكان ابدا اقدر افتح بالعمليه. بنبدا ازاي؟ بنفتح في الابدومن العادي لينير انسيجن، بنرفع شويه البطن، وبنستخدم ممكن تستخدم يا اما صباعك او تستخدم اوفري هيستريكتومي هوك علشان تبدا تجيب اليوتراين هورن. اليوتراين هورن تقريبا بيبقى موجود بعد الكدني بتلاتة من 2 ل 3 سنتي تقريبا بعد الكدني. بنطلع اليوتراين هورن وبنسحب علشان نوصل للسسبنسوري ليجمنت، فممكن تشد السسبنسوري ليجمنت لان هو اتاتشد في الكدني، ده اخر جزء من الكدني وده سسبنسوري ليجمنت. لو شديته بس كده هيتقطع عادي، المفروض ان ما يبقاش فيه بليدنج لان المنطقه دي ما فيهاش بليدنج. لو شفنا البلاد سبلاي عندي بيبقى هو بدايه من الاوفريان ارتري وين في الجزء اللي ورا ده، وده انا هحتاج بعد كده ان انا امسكهم، يعني اعمل لهم بارت فورسبس، اوقف البلاد سبلاي ده علشان ابدا اقطعه وافصل الجزء ده من الاوفري والبرود ليجمنت واطلعه خالص. بعد ما يعني لو احنا شايفين هنا احنا ده كلته انا جاست ان انا عملت بالفورسبس بحيث ان انا اعمل كراشنج البلاد فيزل في المنطقه دي، فبالتالي لما اجي احط السوتشر في الصوره الثانيه تبقى سهله معايا وتقدر تضغط على نفس المكان اللي انا وقفت فيه البلاد سبلاي. بنعملها هنا بسوتشر بتبقى 8 فيجرز بالشكل الموضح ده، بتدخلها لو مشينا بقى معاها 2 3 4 5 تدخل الناحيه الثانيه، وبعدين لما اجي اطلع الابره اطلعها في عكس الاتجاه، وبتعمل كلوجر كويس لل الايت فيجر ليكتشر ده، بحيث ان احنا كده خلاص لجيتشر، بحيث ان احنا نقفل البلاد سبلاي في المنطقه دي، واقدر بعدها ان انا اقطع واطلع الجزء ده كلته بره. وبرده هنا بعمل ترانسكشن في البرود ليجمنت، واخر مرحله خالص ان احنا بنقفل من عند السيرفكس برضو 2 ليجيتشر فوق بعض، وبعدها بنقطع ما بينهم هما
the
دلوقتي هنشوف بقى العملية كاملة في اكتر من طريقة ممكن نعملها بالتراديشنال، وبعدها هناخد باللابروسكوبيك. فنشوف بقى
the umbilicus about right there cranially to about 2/3 of the way to the brim of the pelvis. Just a nice smooth stroke right down through the skin and into the subcutaneous fat. And I'll use cautery here to cauterize some little point bleeders. And like I said, I think cautery makes surgery in general a much more pleasant experience, and I think will improve your results just because it allows you to easily control little point
ده
bleeders
كله بيعمل
and
كوترايزيشن
even bigger
للبلاد
bleeders.
فيزلز.
Cautery is, to me, almost essential in doing surgery. And now we'll extend the incision down through the subcutaneous fat, looking for the linea on the midline, the linea alba. And as you do more and more abdominal surgery, the linea will be easier and easier to find. But I think when you're first starting out, it helps to recognize that the subcutaneous fat comes down in two sheets and attaches right at the linea alba. So to dissect it away, all you need to do is pick up that fat, punch through it with scissors, and just trim it away from the linea alba. And that will bring the linea into view. So here I'm going to use thumb forceps to tent up the linea. Use a 10 blade to carefully incise into the abdomen, and then we'll use Mayo scissors to extend the incision. And you want to lift the inside tip of the Mayo scissor to be sure you're not entrapping an intestinal loop or anything else here that you don't want to cut that's inside the abdomen. So I tented up the linea the entire time I was doing that. Now I'll sweep the intestines forward, and that in many dogs will bring the uterus into shape. Into view. It's an easy way to find the uterus. There's its bifurcation, so we know it's uterus. And now we'll follow the uterine horn to the ovary. So we're now very confident that it's uterus. And we'll get ready to tear the suspensory ligament or fatigue it by placing a clamp on the proper ligament, which runs between the ovary and the uterine horn. There's the suspensory ligament, so I've got a grip with my thumb and index finger on the ovarian pedicle below the ovary, and the suspensory ligament is in the front part of the pedicle. And I'll use my opposite index finger to slowly fatigue the suspensory ligament until the ovary can be easily exteriorized. Sometimes you break the suspensory ligament, sometimes you just stretch it. And now I'll make a little window in a clear area, caudal to the pedicle, and extend it with my finger. And then we'll place our 3 clamps on the ovarian pedicle. That's the bottom clamp there. We'll place the second one about a centimeter above the first one. And then the third one can go through the window and across the proper ligament, just above the ovary. So you can see the ovary below that final clamp there. And now we'll use another Carmalt or other clamp to pass through the window, grasp the end of a piece of suture material, wrap it around the pedicle, and I'm going to start by tying a surgeon's throw, so 1 throw, 2 throws, and then we'll tighten a little bit right above the tip of the first clamp, or the bottommost clamp. So this suture's passing right over the tip, which helps you position the ligature right where you want it, right in the crushed part that clamp left. So I back that clamp off, tighten the ligature, and now we'll add 3 or 4 throws above the first one. Nice square knots. So that's the first ligature. Cut that one. And then we'll repeat the process. And in this case, I'm going to tie the second ligature in a different location from the first one, but not in the crushed area left by the clamp. So kind of the second method I talked about when I talked about the 3 clamp method for doing this. So I'm going to lift up the clamps, make an initial surgeon's throw, tighten that ligature down just below, in this case, the first ligature, just so it's separate from it is all that matters. So you're not tying or ligating the exact same tissue that the first ligature ligated. You're ligating in a different spot, which increases the chance that you get a good tight ligation. So that ligature is done. It's in a slightly different spot than the first one. And now we'll transect the ovarian pedicle below the ovary, but above the middle clamp or the second clamp. You just have to be careful as you do this that you don't accidentally cut something that you don't want to cut. And now I'll check the ovary, be sure we got the whole thing out, that it's not cut, there's not an area where part of it seems to be trimmed away by accident. If you can exteriorize the ovary out of its bursa and it looks like a nice intact ovary, you're good to go. Now I'll grasp with a thumb forceps a little piece of the cut surface of the pedicle, make sure it's not bleeding, No bleeding there, that looks good. And then the last step on this side will be to tear the mesometrium. And what you're trying to do here is avoid the uterine artery, which runs right next to the uterine horn. There for a second you could see it. It's right there behind my left thumb. And the reason we tear that mesometrium is it causes the vessels to spasm and makes them less likely to bleed. Now we'll proceed to the second uterine horn, follow it to its ovary, exteriorize the ovary a little bit, place a clamp on the proper ligament running between the uterine horn and the ovary. That gives us a little grip. Get a grip with our thumb and index finger on the ovarian pedicle below the ovary. Find the suspensory ligament as a sharp band in the front part of the pedicle, and repeatedly fatigue the suspensory ligament caudally and laterally towards yourself is the easiest way to do it. So kind of caudally and towards your belly button. And that will stretch or break the suspensory ligament eventually. And there's the ovarian pedicle. We'll make a window just behind it, so you can kind of tell that pedicle is nothing but fat and vasculature. So these clamps are crushing that fat and allowing you to get a tight ligature. So we'll leave a centimeter or so between the bottom and the middle clamp. That's really important. And the third clamp will go through the window and across the proper ligament. Now we'll get ready to tie the first ligature. So the Quaramalt or other forceps comes through the window, grasp the tip of the piece of suture material, position it over the tip of the bottom clamp, and make 2 throws, a surgeon's throw. Tighten it a little bit, over the tip again, back the clamp off, eventually, and tighten the ligature right in the crush spot. And I think it helps in getting these ligatures tight to be sure you leave a centimeter or so of space between the bottom clamp and the middle clamp. If you don't do that, if you put the clamps right together, the middle clamp will fan the tissue out as long as it's clamping the pedicle and make it hard to get a tight knot. So you want those 2 clamps to be spaced apart a centimeter or so that doesn't happen. Now we'll make the second ligature in a slightly different location than the first one. In this case, I'm doing it below the first ligature, which is probably where you can get it the tightest. We'll complete the knot now. So again, we've got 2 ligatures in slightly different locations on each pedicle. We'll cut that ligature off. And now we'll transect the ovarian pedicle between the bottom clamp, or the middle clamp rather, and the ovary itself, being sure we don't accidentally cut anything we don't want to. And you can tell that ovary is intact. It's peeking out of its bursa, and it looks like a complete ovary, no cut marks in it. I'll start tearing a little of the mesometrium just to get that ovary and uterine horn kind of out of the way. And then I'll pause and check for bleeding in the pedicle. So I'll pinch the pedicle, release the clamp, look for bleeding. No bleeding. We're happy. And then the next step will be to continue to tear the mesometrium, kind of close to but not through the uterine artery. So that just lets you lay that uterine horn caudally. There I was feeling the cervix. We'll place a clamp just cranial to the cervix. Looks like caudal, but it's really cranial. A second clamp with a little space away from the first clamp, and then a third clamp. So on the uterus, if you use a 3 forceps clamp method, each clamp is going to have the same functions that it would if it were on the ovarian pedicle. So I'll make a surgeon's throw. Lay the knot down over the tip of the bottom clamp, back the bottom clamp off, tighten the knot in the crushed area, add 3 throws on top of the first one. So 4 or 5 throws at the most is fine for every ligature you ever do, just so you make sure you get good square knots. That's all that really matters. So that's the first ligature. You can tell that's quite tight. Like I said earlier, for a really big uterus, a pregnant dog or a very large dog or a dog with pyometra, I might transfix these ligatures. But for a medium dog spay like this, I really don't think that's necessary. So we'll tie this ligature below the first one. So you can tell those two ligatures are a little distance apart, so they're not right on top of each other and redundant. They're actually each ligating slightly separate tissue. And now we'll transect the uterus between the remaining two clamps. And we're done with the spay for the most part. The next step will be to use brown Adsons to grasp the uterus itself, being careful not to grasp the actual uterine arteries. If those are going to bleed, you want to see them bleed. So that's the spay. And now we're ready to close. So we're going to close in 3 layers, and I'm going to talk a little bit about details of how to close for those of you who haven't done this often. So the most important area for sure is the innermost layer, which is the body wall, and the critical layer there that you want to get is the rectus fascia. Second layer will be the subcutaneous fat, and the third layer obviously will be the skin. Of those 3 layers, the most important one by far is this first layer that's in the body wall. And again, the critical layer to get is the rectus fascia. The rectus fascia is the ventralmost part of the body wall, but the dog's on his back, so it's the part of the body wall closest to the ceiling. And it's very white and looks like fibrous tissue. And the key to finding it and being sure you pass your needle through it, which is critical because it's the layer of strength, is to visualize it, pick up the layer you want with your thumb forceps like that, and then pass the needle through it. So it doesn't really matter very much whether you suture the peritoneum, which is the innermost layer, or whether you suture the musculature, which is sort of between the peritoneum and the rectus fascia. The only thing that really matters is that you do get the rectus fascia. If you don't get that, it's the layer of strength and you risk having the incision open up. The musculature and the peritoneum provide very little holding strength. And I'm being absolutely certain when I lift the tissue up that I'm not mistaking the subcutaneous fat for the body wall itself. So it's helpful to pull that fat aside like I did just there to get it out of the way. It doesn't matter if you do suture it, you just don't want to suture the fat and the fat alone. If you suture it, you have to be absolutely sure you're also correctly suturing the body wall. And this will just be a simple continuous suture layer. I'm getting bites that are about 1 centimeter thick on each side, and then each pass of the suture is about 1 centimeter or so cranial to the last pass, something like that. It varies a little bit depending on the size of the dog or the cat, but that's approximately what you'll be doing. And then in a second here, we'll be tying the knot, and it's critical that you, if you use continuous patterns like this, get good square knots. And the key to getting square knots that are good and tight is to pull the suture material out to the side, keeping your hands low as you tighten the knot. And when you tighten this last knot, or this last suture, tie this last suture, you're going to be tying to a loop always. So you can see that loop there. And that loop tends to be stiff and want to stand straight up. So a critical part of getting a good square knot is to force that loop to bend over on itself. And that makes it a good square knot. That's a good square knot. I'm tightening each side of the loop there. So I'm going to pick up the midpoint of that loop and really force it to lay down to allow me to make a square knot. It's important to learn to differentiate by looking at it, a square knot that's being tied versus a slip knot that's being tied. Those were all good square knots. And again, the key to making good square knots is to keep your instruments low, keep your hands low, pull directly out to the sides. Now we're going to close the second layer, which is the subcutaneous fat. And this layer has 2 purposes. One is to bring the edges of the skin in a little bit closer to help you minimize the tension on the skin sutures themselves. Skin doesn't like tension. So as much as you can distribute the tension, natural tension on the skin down into these lower layers, the better. And the second purpose of this layer is to close the dead space. So when you trimmed that subcutaneous fat away from the body wall early on in the surgery, you created what we call dead space. And it's possible that a seroma can form, or just fluid collection can form in that dead space. So every few passes of this subcutaneous suture line, I'll get a little bite of the linea itself, or the linea alba, same thing. And that helps again to close that dead space. And so now I'm getting near the end. And you want this layer, and really all these layers of the closure of the incision, to be pretty quick. You're wanting to move on to whatever else you have to do that day. So you don't want to take too long closing the incision itself, but everybody gets faster as they do this. So now I think we're ready to tie. There's our loop. We're going to grab the loop, bend it over, and lay it down. And again, I'm laying the knots down slowly so I can look and watch them as I lay it down and be sure I'm getting square knots. If you do simple continuous patterns like this and don't tie good knots at either end, you risk the suture line opening up. And if you're talking about the body wall, that can be a disaster for the animal. And now in this case, I'm going to place external skin sutures. Skin sutures would be with nylon. Probably more commonly in real life, we use intradermal patterns to close most incisions now, just to avoid having to do a suture removal, but I think it's good to know how to place external sutures as well. So these are going to be interrupted cruciate sutures. So we'll pass the needle through the skin on one side, the skin on the opposite side, then go back, do it again about a centimeter along from the first pass. And then we'll use the needle holder to keep the knot from getting too tight. Throw a surgeon's throw. Throw a second throw. This one has to be left a little loose, and then you can tighten the third one and the fourth one. So if you try to tighten the knot on the second throw, it'll tend to cause the first throw to slip and get tight on the skin. Just place a little Tegaderm bandage on the incision. We'll take the drapes off and the towels off, clean the skin a little bit. And this is just a felt, it's like a gigantic Band-Aid, really. We'll peel the backing off, lay the part that's meant to contact the incision right on the incision, dry the skin, and then it has a sort of cellophane, sticky-backed liner that allows you to stick it to the skin, and then this outer piece of paper can just be peeled away. And it's just a nice temporary bandage that we'll leave on to protect the incision until the dog goes home.
انا سبت لكم العمليه كامله، قطعت حاجات صغيره جدا في النص، بس انا كان يهمني ان انت تشوف العمليه من اولها لغايه اخرها، لان دي typical surgical operation للابدومين، من اول ما فتح طبقات الابدومين لحد ازاي يحط السيزر اصلا جوه، وازاي بترفع الابدومين عشان تضمن ان انت ما تجرحش اي اورجن. برضو السوتشر باترن، وان ازاي بتقفل الجاب الموجود عشان اصلا ما تبقاش فيه جاب. دي الجابس دي اللي ممكن تعمل سروما او تعمل اي مشاكل. دي typical surgery. بس برضو زي ما شفنا انه الجرح كان كبير قوي، فقال لك لا انا مش عايز كده، انا عايزها تبقى حاجه صغيره ما تبانش، العمليه ما تبقاش واضحه. فهنشوف بقى الاستخدام اللاباروسكوبي. حتى المنظار احنا عارفين في الهيومن، يعني معظم العمليات دلوقتي بقت بتتعمل باللاباروسكوبي. ليه؟ لان هو بتبقى فتحتين او 3 فتحات على قد اللي هي البروبس اللي بتدخل جوه دي، وبيدخل كاميرا وبيقدر يمانج الموضوع وهو مور سيمبل، وكمان الفتحه من بره ما تبقاش كبيره. فهنشوف دلوقتي عمليه اللاباروسكوبيك بقى ازاي بيعملوا بيها
Laparoscopic grasping forceps to hold the proper ligament and suspend the ovary and the uterus. And then we'll use this vessel sealing device to grasp the tissue of the ovarian pedicle, apply power, seal it, and use a trigger on the device to transect the tissue. And we'll just work our way across. Now we'll do the same thing to the suspensory ligament, which is traveling down and to the right there. Now that's transected. A little bit of remaining ovarian pedicle needs to be transected, and then the pedicle's almost completely done. And now we'll repeat the process on the uterine horn. So we'll grasp about 1 centimeter, maybe 2 centimeters caudal to the ovary, apply power, seal the horn, and transect it. And if we were doing this open, we'd do it almost the exact same way, except instead of using the vessel sealing device, we'd tie a ligature or two ligatures about a centimeter caudal to the ovary, or a little bit more, and then transect the horn and take both the ovary and the horn out, the very tip of the horn together, being sure to get the whole ovary.
يبقى فصلنا الاوفري تماما. واللابروسكوبي هنا بتعتمد على ان احنا بس بنعمل كوترايزيشن واكسجن بالانسترومنت بتاعتنا. دي برضو عيادة من العيادات اللي هي بتستخدم اللابروسكوبيك.
Hi, I'm Dr. Todd Morgan. When it comes to having your beloved dog or cat spayed, you have options. Now, we are aware that the thought of any surgery to your pet can cause a great deal of anxiety to you and your family. However, having your pet spayed is an important decision to make. Spaying your pet dramatically reduces the chance of breast cancer and infections of her uterus, not to mention preventing any unplanned pregnancies. In the past, there was typically only one type of spay procedure available to clients. This traditional spay procedure has been the same procedure that veterinarians have been performing for decades. Now, there is an exciting new alternative called the laparoscopic spay, or medically termed a laparoscopic ovariectomy. Laparoscopy is commonly used in human medicine and involves placing a specialized medical camera into the abdomen through a very tiny incision, and another tiny incision used for the placement of surgical instruments. This procedure allows for greater magnification of the structures in the abdomen and is far less painful and far less traumatic for patients. We have been performing laparoscopies here at Morgan Animal Hospital since 1997, and we have recently started offering laparoscopic spays to our patients. We have been thoroughly amazed at how well our patients feel and how much quicker they recover after the procedure compared to traditional spay. Well, let's meet Ziggy, who is an adorable 7-month-old Border Collie Retriever cross who came in to have a laparoscopic spay. Her pre-anesthetic blood work was normal, and she was given a sedative and pain medication and started on intravenous fluids to help support her blood pressure during the anesthesia. We administered her initial injectable anesthetic and then provided gas anesthesia for the duration of the procedure. This is the same anesthetic protocol for traditional spays. A traditional spay requires a much larger incision, and the ovaries are blindly stretched or torn from their ligament attachments. This is thought to be a source of post-operative pain for pets. Both ovaries and the entire uterus are removed to the level of the cervix. With a laparoscopic spay, the procedure requires 2 small incisions, typically 0.5 to 1 centimeter long. The first incision is for the medical camera, called the laparoscope, while the second is for the surgical instruments. So during Ziggy's procedure, her ovaries were identified and isolated with endoscopic forceps. A special vessel sealing device was used to cauterize, seal, and cut the ovarian blood vessels and ligament, thereby freeing the ovary from the rest of her uterus. Her ovaries are then retrieved and removed through the instrument incision. The uterus is left intact and in its natural state. Research has shown that there is no actual benefit to removing the uterus. Retaining the uterus will not increase the risk of breast cancer or uterine infections, nor will your dog have any heat cycles. In 2005, the Journal of the American Veterinary Medical Association found that patients undergoing a laparoscopic spay were up to 65% less painful than those undergoing a traditional spay. Along with less pain, there was reduced tissue trauma and a significantly faster recovery time for our pets. Ziggy was monitored closely as she recovered from her surgery and was given additional pain medication to ensure her comfort. After a few hours, Ziggy was ready and excited to go home, back with her family again. Ziggy's owners were amazed and relieved at how quickly she recovered and how fast she was back to her normal activities. There have been numerous medical advances in both human and veterinary medicine during my 18 years in practice, and the laparoscopic spay is the most impressive advancement that can make a really significant improvement in my patient's comfort after surgery. We are excited to be able to offer a less painful, minimally invasive alternative to traditional spays. So when scheduling your pet spay, be sure to consider your options and make the best choice for your pet. Thank you.
العملية اوفريكتومي، شلنا الاوفري فقط. ويمكن برضو لو نتذكر بقى اول سلايد خالص اتكلمنا فيها انه الفيريستريكتومي لو اتعملت قبل 3 شهور غالبا ممكن ينتج عنها urinary incontinence، وبالتالي كبديل احنا ممكن لا هنسيب اليوترس في مكانه، هنشيل بس الاوفري. هو ده المهم لان هو ده اللي بيطلع لي الهرمونز، هو اللي بيعمل لي الهرمونال ديستربنس، وهو برضو اللي هيبقى مسؤول بعد كده على الاوف سبرينج كبيبي. فبناء عليه لو شلنا الاوفري ده هيبقى كافي جدا. السبب ان انا جبت الفيديو التاني ده لانه انتوا بعد كده هتتخرجوا يبقى عندكم عياداتكم، فحته الماركتنج مهمه جدا. يعني شايفه هو بيقول لك ان هو بيستخدم اللابروسكوبي في العياده بتاعته من سنه 1997 97 متخيلين؟ فانا قصدي انه الادفانسد تكنولوجي دي موجوده، is not anymore advanced technology، بس بما ان هي موجوده في الهيومن وان هي ممكن تخلي العمليه بشكل مور سموث والطف، وحتى فتحه الانسيجن نفسها ما تبقاش كبيره، فيبقى ايه لازم استفاد من الحاجات اللي موجوده دي. ده بالنسبه لللاباروسكوبيك اوفريكتومي. طيب هنمشي بقى، هنرجع تاني. احنا زي ما قلنا انه العمليه ovary hysterectomy او ovarectomy actually احنا بنعملها as an elective، فمش بنبقى عاملينها تارجتنج ان انا بشيل تيومر الا في حاله ان انت اصلا عملت يعني جات لك فيه مشكله وبتعمل دياجنوستس بالسونار او كده، فلقيت ان في مشكله فبالتالي بتتدخل بيها. لكن حتى الحالتين اللي انا موضحهم قدامكم دولت اللي هم الاوفرين ابنورماليتيز، سواء السيست او التيومر اللي تحت، الاثنين دول تم اكتشافهم اثناء ما هم بيعملوا عمليه اوفري هيستريكتومي. يعني هم داخلين يعملوا اوفري هيستريكتومي فلقوا انه ده موجود. يعني بيبقى صعب شويه ان احنا نديتكت انه الابنورماليتيز دي موجوده الا اذا كنا بنعمل عمليه. بس لو احنا ديتكتنج فطبيعي ان احنا ندخل نتعامل معاها. العمليه الثانيه اللي هي او المشكله الثانيه اللي بتحصل هي البايومترا، انه اليوترس يبقى مليان بالبص، في انفكشن، في accumulation لبيورولنت ماتيريال في اليوترس. فبرضو محتاجين ان احنا ندخل ونشيل اليوترس عن طريق الاوفري هيستريكتومي. دي لازم يبقى فيها هيستريكتومي، لازم نشيل اليوترس. شكلها عامل ازاي في الدياجنوسز على الاكس راي على ايدينا الشمال؟ لو شايفين اليوترس، برضو خليني هجيب الليزر. اليوترس يعني كبير جدا enlarged لدرجه ان هو زائق كل الاورجنز. يعني شايفين الليفر رايح واصل لحد فين، عالي جدا. يعني دي كلها رابس. كان المفروض ان المستوى بتاعي يبدا الديافرام مثلا يبدا من هنا، لا هو ضغط لي على كل الاورجنز دي خليها تطلع لقدام علشان هو ياخد المساحه اللي ورا دي كلها. فدي اول حاجه احنا ممكن نديتكت بالاكس راي. الحاجه الثانيه برضو بالسنور بيبقى ده الشكل بتاعها باللوبس دي، وبتبقى طبعا الايكوجيناسي بتاعتها بتبقى هايبوجينيك او مايلدلي ايكوجينيك نتيجه للاكيوميليشن بتاع برضو من ضمن الحاجات اللي بتخليني ابقى محتاجه اعمل اوفري هيستريكتومي ان يبقى في فاجينال برولابس هايبربليجيا. البرولابس انه الفاجينا كلها الميكوزا تبقى حصلها بروتروجن وطلعت بره. الهايبربليجيا ان الميكوزا بتبقى الفايبرس تيشو بتاعتها عاليه جدا، هايلي بروليفريتيف، فبتخلي الفاجينا برضو تبقى يحصلها kind of reflection لبره. تراين بلازمس في نوعين، في نوع بيجي في المصل ودي بنسميها الليومايوما او الليوساركوما. والليومايوما او الليوساركوما اوما يعني benign، ساركوما يعني malignant. ودي ده الموست كومن يوتراين تيومر، بيجي تقريبا من 85 ل 90% من التيومر اللي بتبقى في المايوميتريوم بتبقى ليومايوما او جايه في المصل نفسها. however انه التيومر اللي بيجي في اليوتراين جلاند بيسموه يوتراين ادينوكارسي. يوتراين نيوبلازم ان جنرال هي رير في الدوجز، وبيكون معظمها في الكاتس. انواع بقى التيومر سواء كانت اوما او ساركوما هتلاقوها موجوده هنا. زي ما قلنا قبل كده ان الاوما is a benign tumor however sarcoma is a malignant tumor. والمالجنانت تيومر يعني بتشيل، ولازم تشيل، لازم تضمن ان انت لما بتشيل اليوترس والاوفري لازم تشيل معاه الليمف نود، علشان احنا عارفين انه في المالجنانت بيبقى فيه انفيزيف لبعض بعض الكانسر سيلز بتروح تمايجريت للليمف نودز، وبعد كده ده اللي بيخليها يحصل ريكورنس كتير. ففي اي حاله من الحالات اللي بتجيلك دي هتعمل اوفريستريكتومي بلس ان انت تعمل معاها هتشيل الليمف نود. الفاجينال تيومر برضو واحده من الحاجات الفيري كومن، وهتجيت كونفيوز بقى لو انت شفت المنظر ده ممكن يجيت كونفيوز مع برونيال هيرنيا ابسس. ملي هيبقى مع برينيال هيرنيا. طيب علشان برضو اتدخل في المنطقه ديت واعالج الابيسيوتومي،
دي العمليه اللي احنا ممكن نعملها علشان نشيل التيومر right into or right to the beginning of the dorsal aspect of the vulva. And there's nothing really here except for skin, subcutaneous fat, and then the vaginal wall. This area can be a little bit bloody. It tends to be fairly vascular, especially the vaginal wall itself. And now we've placed one arm of the scissors into the vulva, and we're transecting the vaginal wall up into the beginning of the vagina. That's all the farther we needed to go in this dog. But you can go higher if you need to. And you can see the little cluster of grapes, pedunculated leiomyoma there. And now we'll catheterize the urethral papilla. I'll clip the catheter to the drape so that the catheter can't easily become dislodged. We don't have to worry about it slipping out or holding it in. I've placed a pair of Gelpi retractors just to get better exposure, and we'll use an Alice tissue forceps to clamp that tumor and retract it caudally. And now we're going to place a ligature around the stalk, and you want to place this ligature as close to the vaginal wall as you conveniently can. And probably in some cases, because these tumors arise from the muscular layer of the vagina in many cases, you don't really get a complete excision. But these are older dogs. Typically, the tumor's very slow growing, and probably in the vast majority of cases, even if you don't get the entire tumor, it never comes back to an extent that bothers the dog. I've placed one ligature here. You could easily place two. That would be fine, but one seemed pretty solid in this case. And now we'll transect the pedicle or stalk that this tumor is on. And once that's done, all that's left is to lavage and close. So we'll take the urethral catheter out. We no longer need it. Do a little lavage. And then take the Gelpies out and start the closure. And in most dogs, you'll wind up closing in 3 layers, maybe 4 at the most, if there's a lot of fat. The first layer, the layer I'm doing here, is in the vaginal wall. It's a full thickness suture into the vaginal lumen through the full thickness or entire thickness of the vaginal wall. And for this, I would use a rapidly absorbable like monocryl or biosin. The vaginal wall is very vascular. You can see it's oozed a little bit through the surgery, so it heals really well. You don't need a long-lasting absorbable or a non-absorbable here, although a long-lasting absorbable would probably be fine. And I'm just doing a little simple continuous suture line that takes 3 or 4 millimeter bites that are 3 or 4 or 5 millimeters apart. There's no need for interrupted sutures here, and a continuous is just faster. And now we're closing the subcu, and as always when we close subcutaneous fat doesn't hold suture well, so you want nice big bites of this subcutaneous fat. So this is a pretty quick and easy closure. For subcu, I again usually use monocryl or biosin. And now we're closing skin, and I'm closing in a simple continuous external pattern with monocryl here. I like that pattern for these little short incisions. It opposes the skin really well. It looks good. It's very reliable, and it's quick to do. You could use external skin sutures with nylon or polypropylene. You could use an intradermal pattern with monocryl, but I like this particular pattern, and the suture will just fall out when it's no longer needed. And you can see it's kind of a nice, neat closure with good apposition of the skin. So that's it. That's episiotomy. It's really a quick, easy, low complication surgery.
فدي العمليه الاولانيه اللي ممكن تتعمل في الفاجينا، قلنا البيزيوتومي. العمليه الثانيه البيزيوبلاستي. بيجي السكان حوالين الفاجينا ساعات بيبقى عامل فلاب بيبقى كبير اكبر من اللازم. ده بيعمل انفكشن في اليورين تراكت، بيسبب فاجينايتس، بيعمل اودر حته وحشه جدا، اريتيشن وكده. فدي واحده من الحاجات اللي بتبقى محتاجه ان انت تشيل الفلاب بتاع السكان ده. العمليه دي بتتعمل بقى ازاي؟ المفروض ان احنا بنعمل 2 كريسنت انسيجن حوالين يعني بنقيس اصلا الفولد قد ايه من السكان احنا محتاجين نشيله، وهيبقى فيه كريسنت انسيجن فوق وواحد كمان موجود تحت، وبتعمل بقى انسيجن ما بينهم هما الاثنين، بتشيل الجزء ده خالص من الاسكان، وبتبدا ترجع بقى كل حاجه زي في مكانها، بحيث ان انت تعمل تفرد المنطقه ديت وتشيل الاكسس من الاسكان اللي موجود. هنشوف برضو العمليه.
You can just see how much excess skin there is here that has to be taken away, and as you stretch the skin out and manipulate it like that, it sort of becomes obvious what needs to be removed. So I always start by making the external or dorsal part of this crescent or half moon shaped incision first, and then I make the inner part or the more ventral part of the incision second. So I'm just making a half moon shaped incision all the way around this vulva. And there's a lot of excess skin back here, so you can be pretty aggressive about removing skin. And now I'm using cautery to dissect the subcutaneous tissues. There's not a lot of bleeders back here, to be honest, so you could do this without cautery. I just like doing this kind of thing with cautery. It's a little neater for me. And now I'm making the inner part of the incision, which goes almost immediately over the vulva in most dogs. You can see how close to the vulva we are, right above the vulva there. And I've used a couple of towel clamps to retract the skin that we're going to be removing out of my way as I make this inner incision. So once I completed the dorsal dissection, I just used a couple of towel clamps to pull that skin up and out of my way. And now we're dissecting this whole piece of skin out that we'll be removing. Just working my way along. It helps to have a little retraction from an assistant. You can see there that we're really immediately above and immediately around the vulva as we do this. But again, the only anatomic structure you have to worry about is the anus and rectum. And if you've draped those out of the field and just keep them in mind as you go, you're not going to hit anything that you can't hit. There's really not much in here anatomically to worry about except fat and just cutaneous bleeders. So now we're done. We've excised the skin, and here we've cleaned up a little, and we're getting ready to close. So you see we have this sort of U-shaped incision. And there's always with these, or often with these, a fair amount of dead space. So I'm going to close that dead space first. And I like to make these deep subcutaneous sutures interrupted. And one thing that's nice about that is that typically with these, the outer skin incision, or the dorsal one, will be quite a bit longer than the inner one. It's just a circle with a bigger circumference. So if you make interrupted sutures as you close rather than continuous ones, you can spread the difference between the length of those two incisions out a little bit more and just make it wind up looking nicer when you're done. So I'm just placing several interrupted monofilament absorbable sutures in the sub-Q. Nothing really special. But you can see that we've removed enough skin that skin fold and the recessed part of the skin fold are going to be completely gone when we're done. And that's what you want. And I think it's easier to estimate how much skin to take away, again, as I said, if you position the dogs perineally like this. Plus, I just like to work with dogs in the perineal position. It just saves bending over. It's just nice to do surgery where you can stand up straight the whole time. So that's another reason I do PUs in a perineal position too, for that same reason, although you can do PUs with the cats on their back, and a lot of people really love that. And now we're placing skin sutures. Actually, in real life, I would typically use an interdermal or subcuticular pattern, a continuous buried pattern to close one of these, just because it's no fun to do a suture removal in this area. But I'm just illustrating it with external skin sutures here. So these are just cruciates. And anytime we place cruciates in a location where we don't want the suture tags to be irritating, the vulva short and then leave the outer side long to make it easy to remove the sutures. And that's it. That's episioplasty.
يبقى العملية باختصار ان احنا بنيجي على الاكسس سكان اللي موجود ده، بنقدر يعني بنحدد اصلا الفولد اللي انا عايز اشيله قد ايه، بعدها بنعمل 2 crescent incision، بنشيل السكان اللي موجود وبنخيط بقى اللي موجود تحت مع الموجود فوق. سواء كان في الابسيوتومي او الابسيوبلاستي، الاثنين بيتعاملوا في اللي هو زي ما احنا شايفين برينيال بوزيشننج اور برينيال ستيرنم، لانه الحيوان بيكون على الستيرنم والرجلين بتبقى ايه مفروده لورا. تمام، انا كده خلصت الجزء